ISO has actually been involved in anti-tobacco campaign as well during the last 1 year virtually. 6.9% of all new cancers are actually, lung cancer, and mostly it's happening in men, and is the highest mortality cause, cancer-related, mortality that we're having from lung cancer. Now, cancer diagnosis and treatment obviously is a multidisciplinary team approach, and it's more so with early lung cancer as such we see in a very late stage, and it's very important that we educate the people, the practicing doctors, how to detect cancer early. Do see, the doctors do see lung cancer in early stage, but what happens, unfortunately, they are put on anti-tubercular medicine, and by the time they reach the oncologist, it's already quite late. So it's very important that we have more awareness programs, and also it's important that we have a multidisciplinary team approach, especially for cancer like lung cancer, where there are a lot of new technologies which have come up, especially with molecular diagnostics, and there are many targeted therapies which have come up. And I know personally quite a few patients with stage 4 lung cancer who are alive for more than 4 to 5 years being on this targeted therapy. So we have very eminent faculties, national and international faculties. I'll just, although the program is with you, I'll just quickly mention the names. So Dr. Rajesh Mistry, he's a surgical oncologist in Kokilaben Ambani Hospital in Mumbai. Dr. Anuradha Chaugle, she's professor, faculty scientist in Tata Memorial Center, Mumbai. Dr. Natasha Lale, a medical oncologist at Princess Margaret Cancer Center, Ontario, Canada. So she's an international faculty today. Dr. Surinder Dabas, good friend of ours. He's a surgical oncologist at VLK Super Specialty Hospital, New Delhi. Dr. Narasimhan, pulmonologist at Apollo Chennai. We have Dr. Chinna Babu, Hyderabad. Dr. Sabir Zaveri, a very eminent friend of ours in the ISO group, who's a surgical oncologist at Manipal Hospital, Bangalore. We have Dr. Srinivas Chilikuri, radiation oncologist at Apollo Chennai. And we also have, obviously, Dr. Sikumar Pillai, who's the president of KASO. So without wasting any more time, I would request the organizers to take the proceedings forward. We look forward to a very interactive session. And we are going to be much more educated about management of early lung cancer once we have gone through the webinar. And I think there will be a lot of interaction from the audience as well. Thank you very much.
Thank you, Dr. Amna Gupta, for this wonderful kickstart of our meeting. And let me invite Dr. Rajesh Mistry to talk about the special issues, especially surgical issues in management of lung cancer. Sir, please.
Thank you. Good evening to one and all. And first of all, thank you, Chandramohan and his team for the invitation. My topics, actually 2 topics I have been given to present this evening. The first one is role of mediastinal evaluation in early stage lung cancer. And the second one is safety and indications for sublobar resection. So we start off with the first topic, which is role of Sorry, one second. This is one second. Hello, am I audible, Chandramohan?
Yes, you're audible, sir, please.
Okay, so now I can, let's go. So before we actually go into details of mediastinal evaluation, we need to actually understand what we mean by early stage lung cancer. And to help us understand that, I have this table of latest TNM staging of the lung cancer. So patients who have stage T1, T2, or T3, N0, N1, or N2 are said to be patients with early or locoregional disease. Now, it is very important to understand the staging of early lung cancer, as it is important to understand the whole staging, because it is this group of patients where surgery is going to play an important role in the overall management of lung cancer. So the talk is divided into 3 parts: the importance of mediastinal evaluation, different modalities that are available for mediastinal evaluation, and then we'll discuss when to perform or indications for mediastinal evaluation. So coming to the first topic, now, what is the reason to do mediastinal staging? The answer to that is for accurate staging of lung cancer. Now, why do we need to do staging? Actually, the TNM staging serves 3 purposes. One, it tells us, for uniform reporting across the world. Two, it tells us about the prognosis of the cancer based on what stage the patient has presented. And thirdly, it helps us select the best possible treatment strategy for a given patient for a given stage. When it comes to lung cancer, mediastinal evaluation in early stage lung cancer determines two things. One, it tells us whether a patient needs surgery or no. And if yes, then when should it be done? Is it per primum or after some kind of induction therapy? Now, why do you need to give induction therapy? We need to give induction therapy because, as you can see from various studies, it has been shown that patients or the guidelines have been set so that patients who have T1 to T3, N0 to N1 cancers of the lung, they proceed for surgery straight away without any need for induction therapy. However, once the patient has N2 lymph nodes, positive mediastinal lymph nodes, they need to undergo some kind of induction therapy, either chemotherapy alone or chemoradiation therapy. And in fact, there will be some small subgroup of patients who have very advanced N2 disease where there is no role for surgery and patient would proceed to definitive chemoradiation therapy alone. So having understood the need for staging, we now go to different modalities which are available for mediastinal staging. There are three modalities: image-based, endoscopic, and then surgical, which is the invasive method for staging. Coming to the first one, in imaging, we have two modalities: CT scan of the chest and PET-CT scan. Now, when it comes to CT scan, there are various criteria, but one of the important parameters to tell us whether the lymph node is metastatic or not is the size of the lymph node. And if the short axis is more than a centimeter, the risk of that lymph node having metastasis is high. But as you can see, CT scan alone has very limited role because of low sensitivity and specificity. However, once you add PET scan to the CT scan, the overall sensitivity and the specificity goes up, and therefore PET CT scan is an important starting point for staging of lung cancer. Coming to the second modality, which is endoscopic modalities, we have two methods to stage. One is the endobronchial ultrasound and FNA, and the second one is endoscopic transesophageal ultrasound and FNA. Now, these modalities are complementary. A couple of things about endoscopic modalities. These modalities are operator dependent, so you need to have a very trained endoscopist. Two, these procedures will require general anesthesia because accurate staging takes quite some time. And thirdly, it is better that you have a cytopathologist on site because that person can tell us whether the tissue which has been obtained is adequate or not. And then coming to the invasive surgical modalities, we have the standard cervical mediastinoscopy, the video-assisted mediastinoscopic lymphadenectomy, trans-cervical extended mediastinal lymphadenectomy. And then you have the conventional VATS. Now, all these, are surgical procedures which have to be performed under general anesthesia, and not most, but all of them are done at the time of planned surgery. So you start off with this staging procedure, have frozen section. If the nodes are negative, you proceed with the planned surgery. If the nodes are positive, then the patient, the surgery, we don't go ahead with that and plan for induction therapy. Now, all these modalities have limitations. The first limitation is in terms of accessibility of the lymph node stations in the mediastinum. As you can see, EBUS, cervical mediastinoscopy, extended cervical mediastinoscopy, you can access only up to the subcarinal group of lymph nodes. If you add EUS to that, you can go right up to the inferior pulmonary and the posterior mediastinal lymph nodes. VATS, of course, will give you entire mediastinum, but the limitation is that you cannot evaluate the contralateral lymph nodes, contralateral mediastinal lymph nodes. And then, of course, VEMLA and DEMLA will give you access to more lymph nodes, but it is never complete. So that is the first limitation. Sorry, yeah. The second limitation is in terms of the sensitivity with each of these modalities. As you can see, when it is image-based modality, the sensitivity is pretty low. But as you start getting tissue for evaluation, the sensitivity goes up. And you can see where VATS is concerned, where you get the entire lymph node, the sensitivity is maximum. When it comes to again specificity, again image based is not so good. And once you start getting tissues, the the um, specificity increases to almost 100%. Now, which one is better? Is it the endoscopic approach or the mediastinoscopic approach? And to answer that, there are several trials, but I'm going to allude to two trials. One is the Canadian trial, which compared EBUS to CM, which included 159 patients. And this study reported no difference in sensitivity, NPV, and accuracy between the two procedures. So both EBUS and cervical mediastinoscopy were similar in the outcomes. The multicentric RCT of EBUS, followed by EUS, followed by cervical mediastinoscopy, if there were no lymph node metastasis identified on EBUS or EUS, versus directly performing cervical mediastinoscopy, it included 241 patients. And even this study did not find any difference in the sensitivity and NPV between the two modalities. The multicentric trial, in fact, also found that there was significant improvement in sensitivity, accuracy, and upstaging when EUS was followed by EBUS, but the converse was not true. Thus, EBUS alone is good enough if you are not suspecting lymph node metastasis in the posterior mediastinum and the inferior mediastinal lymph nodes. So based on the information that we have, the standard recommended algorithm for staging or evaluation of mediastinum is PET-CT scan, followed by EBUS plus minus EUS, followed by cervical mediastinoscopy. Now, having understood that, we need to know when mediastinal evaluation should be done or what are the indications. But to understand that, we need to understand what are the risk factors for metastasis to mediastinal lymph nodes, particularly occult N2 disease. And several database which is available on the web tells us that central tumors have higher risk of metastasis compared to peripheral tumors. Size of the tumor matters. Increasing size is associated with higher incidence of higher risk of metastasis to the mediastinal lymph nodes, and also higher SUV of the primary is an important risk factor for occult metastasis to the mediastinal lymph nodes. So when do we do it? All patients with peripheral early stage 1A or patients who have obviously advanced stage cancers, they don't require any kind of mediastinal staging and you can proceed with the planned treatment. However, all other patients with early stage lung cancer will require mediastinal staging. And the reason to do this is to confirm presence or absence of metastatic lymph nodes, and particularly true when the primary tumor is very, very small and clearly operable. And to highlight this, this is one case where there is a very large tumor touching the chest wall, size-wise also very big, but the PET scan does not show any lymph nodes in the mediastinum. This patient will need mediastinoscopy because the chances that this person has occult metastasis are very high. However, you have this patient with very small primary or relatively small primary, but if you look at the lymph nodes, there are N3 lymph nodes. This patient, the biopsy from the primary tumor was adenocarcinoma, and mediastinoscopic biopsy of the mediastinal lymph node was actually granulomatous disease. So you converted this patient from completely inoperable to an operable patient. And in fact, this patient is alive and doing well even 5 years after surgery. So it is very important that you confirm histologically presence or absence of mediastinal lymph nodes before planning your treatment. So this is an algorithm which is by the ACCP. Very simply, what we have discussed, if there is peripheral tumor which is very small, there is no need for staging. You can proceed with surgery. If there is a non-peripheral early stage tumor, you have to do a mediastinal evaluation using EBUS stroke EUS. And if it is negative, proceed with surgery. However, if the mediastinal lymph nodes fall in intermediate or high risk, then even if the EBUS and EUS is negative, you should do a confirmation with cervical mediastinoscopy. And this left upper lobe tumors are peculiar. because their propensity to spread to station 5 aortopulmonary lymph node is high, and none of the staging methods would actually give us the answer to that lymph node. So you have to do a VATS to get to this lymph node. So before I conclude this section of my presentation, some take-home messages. Evaluation of media standard lymph nodes plays crucial role in identifying the best treatment option for patients with early stage lung cancer. CT scan of the chest and PET CT scan are important initial investigations for staging of lung cancer in general and that of mediastinum. Invasive evaluation is required for most patients with early stage lung cancer for accurate staging of the mediastinum. The gold standard of mediastinoscopy is challenged by endoscopic techniques, which we should remember. And it is important to adhere to guidelines recommended approach because it will reduce unnecessary surgeries and thereby the cost. Coming to the second part of my presentation, which is safety and indication of sublobar resection. Now, before we go on to that, we should just look at the history or the evolution of pulmonary resection or surgery for cancer of the lung. The first surgery for cancer of the lung was described by Graham in 1933, and that was pneumonectomy. And for next 30 years, all patients with lung cancer were treated with pneumonectomy. Until in 1962, Cahan reported his observation with lobectomy and found that the outcomes were similar when compared to pneumonectomy. And then for next 30 years, and even now, standard of care today is lobectomy. However, Ginsburg et al. From MSKCC in 1994 published their article where they compared sublobar resection to the standard lobectomy. Though their study was negative in the sense that patients who underwent sublobar resection did worse compared to lobectomy in terms of overall survival and local recurrences, people continue to push envelope. And today we have reached a stage where we are actually discussing role of sublobar resection in management of early lung cancer. Now, when we say sublobar resection, there are of two types. One is segmentectomy, where you do anatomical resection of the segment in which the tumor is present. And second is you do a wedge resection, which is a non-anatomical resection. So you have good margins around the tumor. Now, what is good margin is something which everybody should understand. It is described that at least 2 centimeter all-round margin should be there. Or the other way to look at it is that the margin which is taken out should be equivalent to the diameter of the primary tumor. So the ratio should be 1, and that would give you in general a good tumor-free margin if you're doing a wedge resection. But based on the data today, when you're looking at surgery for cancers, segmentectomy is preferred over wedge resection. Okay, now what is the rationale for doing sublobar resection? One, there are a lot of patients because this cancer occurs in patients who are smokers with compromised lung function, and you have patients, you have small tumors, but the lung functions are not suitable even for lobectomy. Now, these patients should not be denied the chance for cure, and they can be tackled with sublobar resection. Though we know now that SBRT also is available for this kind of patients. With advent of low dose CT scan and results of the screening trials world over, more and more people are undergoing LDCT, though they are asymptomatic because of the high risk involved because of smoking. And we are now getting more and more patients diagnosed with sub-centimeter nodules. Now, this may not be very true in our country, though in this last 1 year, because of COVID, a lot of people have undergone HRCT as a screening modality for COVID infection, and we have picked up many more lung cancers, and they tend to be smaller than the general lung cancers which we used to pick up, but still not many subcentimeter nodules that we have seen. Now, when you have subcentimeter nodules, even lobectomy may be an over treatment, and therefore one can consider doing sublobar resection. And a lot of recent studies have shown that the survival between lobectomy and sublobar resection for select tumors, which means early cancers, is more or less similar. So this is one of the first publication which compared lobectomy versus sublobar resection for 1 centimeter tumor. And this came from Pittsburgh, and they concluded that sublobar resections are associated with oncological outcomes which are comparable to those of lobectomy when done for sub-centimeter tumors, suggesting that it may be an appropriate surgical intervention for patients with small tumors. This was a meta-analysis carried out by Dong et al. It included 6 trials, if I'm not mistaken, and they also found that this is, of course, meta-analysis of retrospective studies, but they again found that the outcomes in terms of 1, 3, and 5-year survival were similar between lobectomy and sublobar resection. And of course, to get the best results, there are 2 and I think 3 randomized trials which are going on comparing lobectomy to sublobar resection for small tumors. But from literature, I understand the accrual is very slow, and therefore we'll have to wait for quite some time before we get results of these randomized trials. Now, what are the indications for doing sublobar resection? The one is patient-specific indications, that is when patients have compromised lung function with a small tumor, and 2, disease-specific, when you have tumors which are sub-centimeters and especially GGOs. So indications are early stage lung cancer less than 3 centimeter in a patient with compromised lung function such that even lobectomy cannot be considered, or patients who have lung nodules, small size GGOs, dominant lung cancer with ratio of GGO of more than 75% are candidates who can be offered sublobar resection even in presence of normal lung function. And the reason is most GGOs, they are either carcinoma in situ or minimal invasive adenocarcinoma, and biologically they are very good. So, doing sublobar resection actually is very useful. So these are the kind of patients, these are the kind of lesions, GGOs, where one can consider doing sublobar resection in presence of normal lung functions. The other topic which we need to discuss for small tumors is there need for doing biopsy of a pulmonary nodule before you embark on surgery? Now, the literature tells us that CALGB trial, which is looking at sublobar resection versus lobectomy, their observation was that preoperative biopsy significantly increased the risk of correct diagnosis and thereby avoiding unnecessary or non-therapeutic procedures. That is, at times you will find that the nodule that you have taken out is actually non-cancerous and would not have required surgery. However, with advent of VATS, as we discussed, there are increasing number of GGO patients, and where they trend towards surgery without even preoperative diagnosis. Because technically it may be very difficult to even biopsy or even do an FNAC on these nodules. However, to avoid surgery on benign nodules, following the guidelines for management of SPN, and these are set guidelines, this will help us in identifying nodules which are at greatest risk of malignancy, where even if you can't perform an FNAC or get a preoperative biopsy, it may be justified to go ahead straight away with either a segmentectomy or a wedge resection. And we should always resort to a frozen section if one is planning lobectomy after wedge resection. A little bit of technical aspects of the segmentectomy. So these are the segments of the lungs, and these are the segments of the lungs are actually mini lungs. So you have the artery to the segment, you have the bronchus to the segment, and you have the veins which are there on the periphery of the segment. So each segment has its own artery, pulmonary artery branch. It has its own bronchiole, and it is having the periphery is constituted by the pulmonary vein to that segment. Now, technical consideration as to what to ligate first and how to divide. Now, the order of ligation and division varies from segment to segment. Segments which are very easy to subject to segmentectomies are, apical basal segment, apical segment of the upper lobe, segments which are at the periphery. Now, the rule of thumb is to identify, to ligate whichever structure is identifiable first. So it may be arterial branch, or it could be the bronchus. Whatever you access first should be ligated so that it gives access to the next structure in the hilum of the segment. Uh, Now, how do you identify a segment which should be resected, or the area of segment? One is the clamping method, where you clamp the segmental bronchus and then do inflation deflation so that you get a line of demarcation of the segment. And second is, after ligation of the vascular pedicle, inject fluorescence dye and then see what are the borders of the segment. So this is one example where, after giving indocyanine dye, you can see the outline of the segment which needs to be resected. Now, how do you divide the lung, or the resect the segment out? If you're doing open surgery, then it's very easy to do. You can either use the blunt sponge stick technique or finger fracture technique. But nowadays, most of these segmentectomies are performed with using the VATS technique or the robotic technique. And then in those cases, I think stapling is the easiest way to do it. You have different types of segmentectomies. This is the classical segmentectomy, where the line of division or resection is along the pulmonary vein. You take the bronchial artery and the bronchiole and the pulmonary artery to that segment. So you have the pulmonary vein, the main pulmonary radicle, which is there at the periphery of the segment, then the branches which are going into the segments actually getting ligated or stapled. Then this is the post segmentectomy picture of the lung. Then you have an easy segmentectomy, where it's like doing a wedge resection, where you know approximately where the vein is, and instead of ligating each of these tributaries, you straight away divide it just medial to the pulmonary vein. And then you have an extended segmentectomy, where the division takes place outside the vein. So this has to be based on the size of the nodule, where the nodule is located. Sometimes you may have to do bisegmentectomy if the nodule is straddling between two segments. And wedge resection example is this, where you don't go and look at the bronchiole, the artery, or the vein, just take adequate margins and put a stapler across. Now, these procedures can be done with the standard open technique. You can use video-assisted thoracoscopic resection, or if facilities are available, you can use Da Vinci robot for performing the same procedure, segmentectomy or wedge resection. So before I conclude, some concluding remarks: sublobar resection, which consists of segmentectomy or non-anatomical wedge resections, are indicated for small, low-grade tumors and for patients with compromised lung function. Both these procedures are safe and oncologically sound in select group of patients. However, they are technically demanding, and therefore, not only you should have good anatomy, proper CT scan backup to reconstruct 3D images of the bronchiole and the vessels, but also there should be sufficient experience before you start doing segmentectomies, especially with minimally invasive surgery or robotic surgery. So thank you very much. I hope we have covered all the topics, and I'm willing to take the questions now if it is necessary. Thank you very much once again.
Thank you, Dr. Rajesh Missy. It was actually a wonderful talk. Can you unshare your slides so that Dr.
Yes. Yes.
And in fact, you have pretty much covered everything, including the technicals also. Being the fact that most of the delegates are surgical trainees and surgeons, I think it's very much interesting. Perhaps we'll come back to the discussion later on. It's very, very exciting. Thank you, sir. And next we'll go to the an important lecture by Dr. Anuradha Chowgule. She's a faculty scientist in PMH, and she'll be talking about the new era methodology, which is the targeted detection of therapeutically targetable EGFR mutation in early lung cancer. Dr. Anuradha, please.
Yeah. Can you see my slides? Am I audible?
Yes, okay. You're audible. You can see your slides.
Okay. Thank you, Dr. Chandramohan, and your organizing team for inviting me for this wonderful platform. And my topic given is the detection of therapeutically targetable EGFR mutations in early lung cancer. So, what I'll be covering are what are the different biomarkers testing in non-small cell lung cancer, EGFR mutation in what is the significance of EGFR mutation in lung cancer, which are the samples used for EGFR testing, what are the different platforms used for EGFR testing, and what are the guidelines recommended for EGFR testing in early lung cancer, and how do we interpret the EGFR results on the either on the real-time platform or on the NGS platform. So these will be my main key takeaways. So what are the biomarkers testing in non-small cell lung cancer? As you all know, apart from EGFR testing, the most predominant is there are various types of biomarkers involved in not only in the genetic in the clinic, but also it is helping as a complementary for the classification of the histologic types. As you can see here, there are various genetic alterations in the adenocarcinoma, which are different from the squamous cell carcinoma. And one of the important as the FGFR1 amplification and EGFR overexpression, which you can see predominantly in the squamous cell carcinoma as compared to the adenocarcinoma. So there are various targets which are available today. As you can see, the whole spectrum like EGFR, ARC, MET, HER2, ROS1, BRAF, RET, and TRAC, PIK3CA, MEK1. So these are the various targets which are available today with the targeted therapy. Now, what exactly are the targeted therapy? Where they specifically target the genetic alterations which has happened as compared to the chemotherapy. And it also this targeted therapy helps in reducing the toxicity as compared to the chemotherapy. So here I would like to mention about this particular NTRK fusion, which is there where earlier only the entrectinib which was approved by the FDA, US FDA, but now you also have the larotrectinib, the drug which is available. Similarly, with the PIK3CA, which is a high topic today in the clinic or clinical oncology, where from the phase 3 clinical trial, now you get an FDA approval drug, which is alpha specific PIK3CA called as alpelisib. So this whole spectrum helps in the lung cancer to treat the patients apart from the chemotherapy. So what exactly is the EGFR mutation we would like to see? So you all know that EGFR is the most important marker before starting the treatment for the chemotherapy. So we should know what status it is, whether it is positive or negative. Here is the overall frequency rate across of the EGFR seen at the global, right from the various overall highest found in the Vietnam with the 64%, and you go in the west where in the USA you get to see a very low percentage of overall frequency rate in the EGFR mutation. So what exactly is the EGFR? It is the member from the ERK family of a receptor tyrosine kinase, and this EGFR is a transmembrane glycoprotein with an extracellular EGFR factor binding domain and an intracellular domain where you can see the down signaling pathways which are involved in the normal cell growth, proliferation, and differentiation. So, but however, if there is a loss of this ligand and if the EGFR mutation starts constitutively activating, it triggers the tumor cell growth and thereby dysregulating the whole lot of signal transduction pathway which are involved like EGFR, RAS pathway, RAF pathway, mTOR pathway, and totally dysregulates the proliferation, invasion, angiogenesis, metastasis, and there is an inhibition of apoptosis. So, what exactly, as I mentioned, the EGFR has an extracellular and an intracellular binding. So down the signaling pathway of the intracellular EGFR, you can see that this EGFR is comprised nearly of 28 exons, out of which there are the somatic mutations have been observed on this tyrosine kinase between the exonic region of 18 and 21. So coming down to this exon 18, which is a nucleotide binding loop, you get to see the various rare mutations like G719C, G719S, and G719A, and these are the predominant one. which are supposed to be the rare mutations, and they partially respond to the TKI inhibitors. Coming to the most prevalent one is the exon 19 deletion, which are nearly comprised of nearly 29 deletions or so, and it covers almost nearly 55% of the EGFR mutation. Coming to the exon 20, which is also considered to be the rare mutations, where you get to see at the baseline the various insertions and deletions, and also the S768I mutation. Again, it is considered to be a partial responder. This T790M mutation, earlier when there was a sensitizing exon 19 and 21 treatment, that thereafter, after 3 to 4 months, the patient goes into progression, or it starts acquiring a resistant mutation called as a T790M mutation, which is nearly seen in 50% of it once the patient goes into recurrence. However, now with the second line generation treatment like osimertinib, this also has been overcome. The patient can really recover from this acquired resistant mutation. So whether, as you can see over here, this is approximately, now since this is being early stage cancer seminar, so we can see over here, as per the literature, approximately 30% of the NSCLC patients are present in the early stage, with the stage 1A to 3A. And the primary treatment of which today is the surgery or the adjuvant chemotherapy, as you have heard just long time, just with the earlier speaker. So is this EGFR TKI going to be useful in this early stage cancer, or is there an overall mutation, or is there a mutation rate compared to the stage 3 and 4? So there is a randomized trial, phase 3 trial of ADURA, which has shown a promising results of osimertinib, where you get to see the patients of exon 19 and exon 19 and L858R in this early stage cancer. This is a very small data where it suggests that from stage 1 to stage 4, almost in the Indian population, in the Asian population, it has showed a similar overall frequency rate around in the 30 to 40%, and in the Caucasian also it has showed a 10 to 20%. So if this EGFR data was available, this TKI definitely they would have responded well to the EGFR TKIs and inhibitors, and similar portions of patients would have been able to benefit as compared to the advanced setting as well. So what are the samples used for EGFR testing? So let us see. So as mentioned earlier, the tumor biopsy samples, which can be either of the surgery or the bronchoscopy, and the preferred sample for type are the FFP samples for the genetic mutations in advanced non-small cell cancer. You also you can also do the EGFR testing or the biomarker testing on the cytology samples, like bronchoscopy and the thorax synthesis and the fine needle aspiration. The sample quality, however, the sample quality and the tumor cell content may be lower as compared to the biopsy samples. So the cancer cell content of cytology samples are relatively low to the biopsy samples you can see in the early stage cancer. So of course, and now the liquid biopsy is also becoming a promising tool in detecting. So you can not only the blood plasma, but also if there are some other body fluids, which can be also used as a baseline sample to detect the various biomarkers in the setting. So let us see which are the types of diagnostic modality. Like you can use bronchoscopy, that is the EBUS, so where the specimen types are endobronchial biopsy, transbronchial biopsy, brushing cytology, washing cytology, and FNSC cytology, and where you can have nearly 58 to 94% depending on which lesion is visible and which biopsy is which can be used as a biomarker. So adequacy for this biomarker, yes, we need to have less than 50% washing and up to 100% for the endobronchial biopsy. Coming to the surgical side, you can have the mediastinoscopy, thoracoscopy, resection, and the biopsy specimen type is the tissue biopsy, that is the FFP sample, and the diagnostic yield really you get to see remarkably high with the 80 to 97%. Coming to the image guided like TTNA, you get a specimen type of CNB, FNAC cytology, fluid cytology, and the bone biopsy as well. But however, the diagnostic yield varies from 57 to 95%, and the insufficiency rate of this is around 3.7 in one series of fluorescent tests, with 100% in one series in TTNA. For bone biopsies, because of the decalcification hurdle, it the we get to see a very low percentage of EGFR mutation, and there can be a false negative EGFR mutation as well. So the rapid onset evaluation of acquired samples need to be ensured how the collection of adequate tissue sample has been provided for the molecular testing and all. And here the pathologist plays an important role in the tissue, how it should be used in a very in an adequate way. Okay, now coming to this, as you can see over here, whether it's a biopsy or a resection, the EGFR mutation status has not differed. It has almost remained the same with 54% and with the 50%. However, the resection has been done more, around 77%. So the EGFR mutation status doesn't differ at all. You can see whether there is less false positive or false negative in both the EGFR mutation status. So what are the problems in having the tissue in the lung? So there are various problems like tissue samples are fragile, there can be a degradation which starts upon removal from the body. And sample, once as soon as you get the sample, they should be proceeded fast for the analysis or they should be fixed immediately to preserve the tumor characteristic. So this is a very important thing. They should be transferred immediately to 10% formalin fixation, and the most common one is the preferred is which allows for histologic and the molecular analysis. There should be also 70% ethanol fixation, which is most commonly used for the cytology samples, but they are not at all suitable for the most histologic samples. Yeah, so what are the things? As I mentioned, 10% formalin fixation leads to the chemical cross-links to the proteins for the RNA and the DNA. So the fixation, if it is not complete until the formalin has fully penetrated, the tissue can be a problem and there can be an individual chemical reactions which has to be completed. The duration of the fixation must be long enough to allow for both complete penetration and complete fixation. What happens if there is an underfixation? So molecules in underfixed tissue will begin to degrade, compromising sample quality and negatively impacting the test results. And if there is an overfixation, extended fixation can cause DNA mutation, damage, breakage, and hinder the target protein detection in IHC analysis as well. So ideally, there should be more than 200 tumor cells present in the sample. Fewer cells are acceptable, like if you are doing a very sensitive method like real-time PCR, 10% tumor cell content are also acceptable. For the Sanger, it is just 20%. But if you are going to perform it on NGS, so you need the tumor cell content at least between 20 to 30%. So the proportion of the sample that is tumor should be more than 50%. Although with good technical procedure, the reliable results can be obtained only with the tumor percentage, as I mentioned, between 10 to 20%. So tumor cells are identified by their overall size and shape, and the size and shape of the cell nucleus and the amount of necrosis which is determined. Now coming to the various platforms, which are the platforms which are used for the EGFR testing. So for as a single gene platform, you can perform it as a on the real-time PCR technique, and there are various platforms commercially available like Roche, Quigen, AmoiDX. So almost Roche can detect up to 42 mutations in exon 18, 19, 20, and 21. Then you have the limit of detection is up to 2 to 3%. However, the COBAS, which is the Roche one, is been acceptable as an FDA approved technique to perform the single gene EGFR PCR. Coming to the Quigen, it is also sensitive, which detects around 29 mutations, and it has a sensitivity up to 1%. Coming AmoiDX, also it has about 29 mutation detection system, and the percentage of it also remains from 1% to 0.2% for the plasma super. So coming now to the digital PCR, this is the BIRAT digital PCR, where you can get to see the absolute quantification number of the EGFR, and it can be used for the monitoring residual disease as well. So it is also highly sensitive, and it has a very 0.2% limit of detection. Now, it's just not the single gene EGFR which is essential in the clinical oncology, but now the whole broad spectrum, as you saw, that KRAS, BRAF, PIK3CA mutation, where all the druggable markers are available, that can be has to be performed on the next generation sequencing, because tissue is an issue and it has to be adequately used. And here the nanogram which is required, the DNA which is required, is hardly 1 to 2 nanogram. So this platform is very highly sensitive. There are two platforms which are available from Illumina, like MySeq, and also from Thermo Fisher, which is based on the semiconductor, which is an ion torrent. They're highly specific, they're highly precise, they're highly sensitive, where you can go up to 0.1 to 0.5% of the detection of the EGFR status. So these are the, as I mentioned earlier, the advantage with Roche is that it is an FDA approved method for the mutation analysis, but it does not give an absolute quantification of the mutation. It only detects the mutation, which is the main problem with all the real-time PCR platform. And here in the BIRAT system, you get to see the absolute quantification is high sensitive and a high specificity, but it detects only the known targeted mutation. And as in NGS, apart from your known targeted mutation, you can also go for the whole exome, whole genome sequencing, where you get to see the lot of novel mutations as well. You can detect the indels, you can detect the copy number variation. So it has more advantage over the real-time PCR platform. So what are the guidelines recommended for EGFR testing? As there are well-established guidelines for the advanced cancer, but here in the early lung cancer, the EGFR, the NCCN guidelines says that if there is a adding molecular testing for EGFR mutation to be performed on the diagnostic biopsy or post-surgical resection sample, we need to do the EGFR mutations results if they're available for the adjuvant treatment decision for the patient with the stage 1B to 3A NSCLC. However, the data, there is not much mature data of EGFR mutation rate in the early stage cancer. So how do we interpret the reports if there it is on the EGFR if it is on the real-time PCR platform? So you need to know which mutation is there, whether it is exon 19 or 20 or 21, and in that which is the exact mutation which is present. Like in the under the exon 21, you need to know whether it is L858R or L861Q, because there is a lot of difference if it is an L861Q is said to be a very rare mutation as compared to the L858R, and this mutation is going to be a partial responder. So this is how the genotype is reported, whether the mutation is detected, and if it is detected, which type of mutation is present. So these were what are the key takeaways as per the guidelines? All non-small cell adenocarcinoma patients need to go for the EGFR testing, as you can see. So we need to do the EGFR testing in the early stage cancer as well, because almost the mutation rate was similar, which was found across all the disease types. To take an informed treatment decision, patient may get EGFR mutation tested at diagnosis, and tumor tissue is still remains the gold standard for successful EGFR mutation testing. However, if tissue is an issue, if there is not much of the tumor content and there is no biopsy available, one can go with the cfDNA liquid biopsy testing for the EGFR mutation as well as per the NCCN guidelines. The tissue-based EGFR mutation detection on RT-PCR platform is the FDA recommended testing method. But however, we have seen the various biomarkers are today present in the lung cancer, and these are there are the druggable markers, and they can be easily targeted. So one should prefer the NGS platform testing if it all for the EGFR mutation as well. But however, EGFR mutation is a required report at earliest to the clinic. So if we can give it as a complementary EGFR mutation report, because it can be given within the week. So EGFR mutation report should be given at earliest, and then the NGS platform, NGS reports can be given. So thank you so much. This was my talk for today's presentation
Thank
for
you,
the
Dr.
early lung
Anjana.
cancer.
Dr. Can you stop sharing your slides? It was a
Yes.
fantastic talk.
Yeah.
Actually, you made it very simple for the surgeons. Surgeons seldom understand molecular tumor, and now it's so simple for us. And thank you very much. And let me invite the next, in continuation with this recent development in the molecular testing. The one branch which is very much advancing in lung cancer is medical oncology. Every year it comes with new and newer modalities moving towards the molecule, targeting things, and none other than Dr. Natasha Lale is qualified to talk about it, because not only she's a very eminent medical oncologist in Canada, she's also a good researcher. Any ASCO meetings will be having many presentations by her. Dr. Natasha, please go ahead with the presentation about recent developments in the systemic therapy of lung cancer. Over to you, Dr.
Great.
Natasha.
Thank you so much, and I'm honored to be here. It's lovely to be in Kerala again, although I would of course much rather be with you in person, but perhaps next year or the year after. So I'm delighted to talk a bit about recent advances in systemic therapy for early stage disease. And it's wonderful to be in a meeting with the surgeons here in India. These are my disclosures. I'm going to talk a bit about current systemic options with a real focus on targeted therapy for EGFR and some late breaking news in the immunotherapy area. So as Dr. Anuradha has nicely illustrated, there are many genomic subtypes of lung cancer with many targetable drivers. And on the right, you can see that with chemotherapy, we can achieve, even in stage 4 disease, a 15% rate of 5-year survival now, which is really unprecedented for advanced disease. But with immunotherapy and targeted therapy, we now have stage 4 patients living more than 5 years, more than 30%, and in some cases, for example, with ALK-positive lung cancer, more than 50% of patients live 5 years or more. So when you think about this, it really becomes very interesting to ask, how can we improve the current standard in early stage disease? And it's interesting, you know, there's always the academic and the real world. On the right, the ISLC with the latest staging system has shown us that, you know, some groups with lung cancer have 5-year survivals of as high as 90%, a bit like node-negative breast cancer. But on the left, this is from a US database. The real world, in fact, does not perform quite as well, with lower survivals at about 70%, more like high-risk node-negative breast cancer. And both here in Canada, as well as India and around the world, adjuvant cisplatin-based chemotherapy is standard, although I know none of the patients like it, but they get through it. And in particular, it's widely given for stage 2 and stage 3 resected disease. So you can see on the left, this is with vinorelbine and cisplatin, a hazard of 0.66 for stage 3 disease for overall survival, 0.74 for stage 2, but no improvement in stage 1, although in North America, we do offer it to patients with larger tumors. And what I really like about adjuvant therapy is on the right, that, you know, you can take at the very bottom curve a patient with stage 3 disease, and with adjuvant chemotherapy, transform them to the same prognosis as someone with resected stage 2 disease. And similarly, people can go from stage 2 or 2B to 2A or 1C, and so on, although not yet in the earlier stages of disease. And so I thought I'd share a case. This is a patient of mine. He's 70, he's Vietnamese, he's an ex-smoker. And interestingly, he has a respirologist. I'm not quite sure why, but she does routine chest x-rays, and she found that he had a right upper lobe mass. I think there was a concern of TB when he immigrated, but otherwise he's very, very well. So 4 years ago now, he underwent workup. He had EBUS mediastinal staging and tumor sampling, and was found to have a T2N1 adenocarcinoma with an EGFR mutation, exon 19 deletion at resection with low PD-L1. So of course the question becomes, what should we recommend? And, we're not really limited to vinorelbine and cisplatin anymore. In the ECOG 1505 study, we learned that really any novel triplet is a benefit with cisplatin. And in particular, I think there's growing interest in the use of pemetrexed, which you can see at the top right. And in the right-handed panel, I just wanted to remind people that in patients with EGFR mutations, they too derive benefit from adjuvant chemotherapy. At the bottom, you see patients with exon 19 deletions, and those that were treated with observation or observed after surgery had a worse prognosis in blue than those that got adjuvant chemotherapy. And I apologize, there's some window washing happening behind me. So should we offer these patients chemotherapy or adjuvant TKI? And this is one of a series of 3 studies that we've heard about in the last couple of years. The adjuvant study from Sitong in China, where patients were randomized to gefitinib or adjuvant vinorelbine cisplatin. And as you can see at the top right, better disease-free survival with the TKI, but not better overall survival. And we saw the same story at ASCO this year, this time from a study from West Japan. Patients were randomized to adjuvant gefitinib or cisplatin, and again, perhaps better disease-free survival, although these curves do cross the top right, but not better overall survival, and that's with 70 months of follow-up. And the last study, which was interesting and I think a bit more exploratory, also from the Sitong group, a preoperative trial of TKI or preoperative chemotherapy followed by adjuvant therapy. And again, improved progression-free survival, but no difference in overall survival. So what did we do for my patient? The standard in Canada and North America is that even with an EGFR mutation, you would offer patients adjuvant chemotherapy for stage 2 and stage 3 disease and larger tumors that are N0. But we also had a chance to enter him in the ADORA study. Dr. Anyarada talked about this as well, and I know you're familiar with these data. Patients could be either treated or not treated with adjuvant chemotherapy, resected stage 1B, 2, or 3A, and this is by the 7th classification. So by the 8th classification, this does change a little bit. Most of these patients are now stage 2 or 3A, and they had to have classic sensitizing mutations. They were also stratified by Asian or non-Asian background, and they either received osimertinib at standard dose for 3 years or placebo. And the IDSMC recommended that this be unblinded, and the study closed, and all patients crossed over to osimertinib. And Roy Herbst, as you remember, presented this last year at ASCO and was presented with Professor Yilong Wu as the first author. And as you can see on the left, this tremendous disease-free survival benefit, a hazard ratio of 0.17. And when we look, and that's in the primary analysis population with resected stage 2 and 3A disease or node positive disease, and when we include all comers, you can see still a very impressive hazard ratio, 0.20, and those curves are incredibly impressive. And of course, just like adjuvant chemotherapy, the benefit is greatest in those at higher risk. Those with stage 1B disease, a hazard of 0.4, stage 2, 0.17, and stage 3A resected, 0.12. Also important to remember now that in the 8th classification, a lot of our N2 patients that might go under resection now technically may also have stage 3B disease. So I think sometimes staging serves to confuse us more than to clarify. And what about the difference by chemotherapy? And these data were presented earlier this year in Singapore or virtually. And you can see in the middle that patients with or without adjuvant chemotherapy both derived proportional benefit. And this was seen across stages with no clear difference in terms of the proportional benefit. So does that mean that we can substitute adjuvant TKI for adjuvant chemotherapy? My answer is no. I think if your patient should have adjuvant chemotherapy, they should go ahead, but at all costs, please make sure that your patient doesn't miss out on adjuvant TKI. The survival data, intriguing, but of course very early. And what was interesting is that the largest rate of recurrence or the greatest prevention of recurrence was in the CNS, which of course we know is specific to osimertinib and its benefits as opposed to earlier generation TKIs. But the question will remain after 3 years of osimertinib, will these curves come together or will they continue to stay apart, and will we have cured people? In terms of tolerability, only 11% of patients stopped treatment during the 3 years and 7% reduced doses. And when we look at quality of life, also presented at the World Conference on Lung Cancer, sorry, this is a little grainy, patients really maintained their quality of life, whether they received adjuvant osimertinib or not after surgery. So that's quite reassuring in terms of our patients getting through treatment. So of course, what happened to my patient wasn't he randomized to placebo. It's always the way. And after about 1.5 years on placebo, just around the time of the ASCO announcement, as I was trying to cross him over, he developed enlarged lymph nodes, as you can see on the right on CT. We did a PET. These were PET avid. I sent him back to the surgeon because, of course, I was desperate to use the ADAURA approach. And the surgeon discovered that he had positive disease at 4R and also significant PET uptake at station 2R. So we discussed him at our tumor board. I desperately wanted surgery. The surgeon said, no, Natasha, we should treat this gentleman with curative chemoradiation and then consider the Pacific trial. So we have gotten him through concurrent chemoradiation. We actually used the PROCLAIM study or with pemetrexed and cisplatin as concurrent chemotherapy. And we did have a nice update on the Pacific trial showing that now these patients have a 43% 5-year survival with durvalumab following concurrent chemoradiation for those with unresectable disease. But again, in the box on the right, you can see that those with positive EGFR mutation, it's still unclear. Better progression-free survival, but is overall survival better? And also for those with PD-L1 negative disease at the very bottom, placebo is still just as good. And so, it becomes very difficult in practice what to do if we give him durvalumab and he relapses. Can I give him osimertinib or will he get pneumonitis? And so these are the debates that the patient and I are currently having. And on balance, he said to me, if a year of IV therapy is not going to help me, why would you make me do it? So for now, I'm a bit nervous, but we're just watching and waiting to see if he will recur. And so I think that really, brings home the fact that whenever possible, we need to resect these patients and give them adjuvant TKI. So we also had a nice update about adjuvant immunotherapy. Dr. Wakely presented these at ASCO from the IMpower 010 study, where patients, again, that had adjuvant chemotherapy with resected 1B to 3A disease using the old staging system, either received atezolizumab or best supportive care. And it's interesting, you can see that they had almost 1,300 patients that were initially enrolled, about 1,000 that completed chemotherapy, and a slightly smaller number that were randomized. And they had a number of populations where they looked at outcomes, and their primary analysis population on the left were patients with resected stage 2 and 3A disease, completely resected and PD-L1 positive. And although they did use their own in-house analysis, the SP243 assay, this probably is reasonable in terms of PD-L1 score. Some might argue it's not quite as sensitive, but I think it is a reasonable assay. And you can see a significant improvement in disease-free survival. It's not like what we saw in ADAURA, but one might also argue that this is a tougher group of lung cancer patients and that perhaps salvage with subsequent immunotherapy won't be the same as it will be with subsequent salvage with osimertinib. The disease-free survival hazard ratio 0.66, 2-year differences 75% compared to 61%, and at 3 years, 60% compared to 48%. So very impressive, even 3 years out after finishing a year of therapy. They also looked at all randomized patients from stage 2 to 3A, again, a significant hazard ratio, 0.79, but when they looked at all patients, this did cross the significance boundary, but still the hazard was 0.81. So what's my prediction for this particular study? It's my expectation, as I'm sure it is yours, that this will be approved by the US FDA within the next month or two. And then the challenge, of course, will be for the rest of us. Can we afford it? And is disease-free survival enough? It was very interesting to see on the right in the forest plot that PD-L1 expression was really the major driver of DFS benefit, and those with the highest tumor cell expression, 50% or more, appear to derive the greatest benefit, while those with PD-L1 negative disease, perhaps just like in Pacific, might do just as well without. So I think it'll be very interesting to see what the other trials in this area show. Again, a tantalizing early look at survival, not significant, not expected to be significant, and we'll have further updates on this in the future. But who should go first? We've heard a lot of data about preoperative therapy, particularly with immunotherapy. So should we give patients a test of immunotherapy first, or should they have surgical resection? And we've learned in mice, and in mice with melanoma in particular, that a preoperative approach is better than an adjuvant approach, as you can see in the bottom right. Patients with adjuvant PD-1 inhibitors have a slightly inferior survival than those with preoperative inhibitors, as you can see here in blue. And we believe it's because if you have the tumor in situ, you can really ramp up that T cell specific response, and then you'll have those specific T cells that can circulate after and mop up any residual disease. And we saw some data both at ASCO and AACR this year, looking at the Checkmate 816 study, where patients received either preoperative nivolumab plus chemotherapy or cisplatin-based chemotherapy alone, and then went to surgery. There was also a group of patients that received combination immunotherapy, and their main endpoint was to look at the rate of pathologic complete response. And, it was very interesting to see this, a dramatic increase in the rate of pathologic complete response, 24% with the combination versus 2.2%. If we look at those patients that went to surgery, it was 30% compared to 3%. And the overall response rate, perhaps not quite as different, 54% with any shrinkage versus 37% with chemo alone, and downstaging 31% versus 24%. I think the other thing that we learned at ASCO from this trial is that there was no increase in surgical complications. Similar number of patients went to R0 resection, and there was no real increase in surgical wait times or other challenges, although patients did have more adverse events from immunotherapy. So I guess the question in my mind is, can preoperative therapy help us figure out who's most likely to benefit from adjuvant therapy rather than just an all-comers approach where we treat all patients? And this is a patient that I had tried. She's an ex-smoker. She has a rapidly growing squamous cancer. We tried to put her on one of the preoperative chemo IO trials, but it took us so long to get all of her tests done. You might find this in India too with trials to ship everything to the US. That she had a little tiny lesion on her liver. So both the patient and I panicked. We spoke to the surgeon. We treated her as advanced disease off protocol with chemo IO. And you can see a very nice response on the right with really resolution of the tumor. The liver became normal after 4 cycles. Everyone went back. And although they were initially worried, 2 multidisciplinary tumor boards said, well, you can't say that the liver was involved. So perhaps this lady should either have surgery or radiation. And of course, in my mind, if she goes for surgery, this is a lady that I would really like to have on further checkpoint inhibition. But it's a bit of a challenge. There are at least 5 adjuvant immunotherapy trials, of which we've now seen the result of 1, and 4 peri-adjuvant trials where patients get a combination of preoperative and postoperative, but they don't really compare to each other. And so just like with chemotherapy, where people give 3 to 4 cycles pre-op or 3 to 4 cycles post-op, and we believe that the outcomes are similar, do we have to ask those questions again for immunotherapy? And I think the world is really hoping that we won't. And are there other things that we can use to select who might benefit? Dr. Anuradha mentioned cell-free DNA or liquid biopsy, and we know that this is prognostic, not only before surgery, but also after surgery. Patients who have positive cell-free DNA in plasma have a much higher risk of recurrence. And is this a group perhaps that we could select for more expensive therapies in places like Canada and India, where money is always an issue? So, I have a couple of Canadian questions about systemic therapy in advanced disease. These include, is disease-free survival enough? Should we wait for overall survival and cure? How do we ensure that molecular testing in early stage gets done? We have Dr. Anuradha who told us some of the approaches, but how do we have that whole scale approach? How do we afford it? How do we make it routine? And in Canada, testing takes quite a while. So could we even do a little ddPCR or liquid biopsy before surgery? And that way we can stream all the EGFR patients out, all the KRAS patients out, and so forth. How do we make sure that the surgeons refer those patients with small node-negative tumors for adjuvant TKI therapy? Do we think the disease-free survival benefit is enough in that group? And how do we make sure that we don't replace adjuvant chemotherapy with a wholesale switch to adjuvant TKI or adjuvant immunotherapy? Other questions, of course, that medical oncologist asks: what happens when these patients relapse? Can we re-challenge them with TKI or immunotherapy? What do we do if the patient didn't have an R0 resection? We'll hear from our radiation oncologist next, but now that adjuvant radiotherapy is no longer popular, what do we do about these patients? And will it change what we do in stage 3 disease? Will more of our patients go to surgery because it's technically feasible and we'll be able to give adjuvant therapy? And I'm hoping the answer is yes. And of course, finally, can we have a more customized approach? Can we use postoperative cell-free DNA or even a preoperative window of therapy to see who's really going to benefit from these treatments, as opposed to who is just having futile therapy and expensive toxicity? So what about other studies? This is the Alchemist study, where they're still looking at adjuvant TKI with erlotinib, I believe this one is, ALK positive, looking at crizotinib, and the ECOG group is looking at nivolumab. The Canadian group is looking at durvalumab, and of course the ORTC is looking at pembrolizumab, and so all of these will be reporting soon. In the TKI world, I don't know if any of you are participating in this trial, but it's a preoperative study of chemotherapy, osimertinib plus chemotherapy, or osimertinib alone. Chemotherapy data, of course, from a very exciting Indian trial and Japanese trial looking at major pathologic response and PCR. And expanding this, can we look at all of these different subtypes? And there are currently efforts in the US and North America trying to target all of these different baskets of patients. So I think with improvements in systemic therapy, and thanks to the wonderful work of our surgeons and radiation oncologists, we are closer to curing more patients than ever. Adjuvant osimertinib is practice changing in many jurisdictions in resected 1B to 3A lung cancer patients, but we still recommend chemotherapy in those with no positive disease. I think adjuvant atezolizumab will change practice in those with PD-L1 positive resected 2 and stage 3 and 2 disease. And our challenges are going to be how to get molecular testing done in time, how to get the right patients referred, and how to get the right patients treated, including affording treatment. And so with that, I'm going to stop. I want to thank you very much for the chance to be with you today, and I'm really looking forward to further discussion.
Thank you, Natasha. We always have very high expectations out of your talk, and you never disappoint us. It's fantastic. And one thing is very sure, now maybe in another next decades or so, neither surgery nor chemotherapy is going to cure lung cancers. It is all going to be at some other level with some other platform. I think it's amazing lecture. Thank you very much. I think we are going to discuss these things again. Please stay back. Dr. Surendra Dabas, can you go ahead with your panel discussion? Because I will launch a poll also. All the delegates and panelists, please answer those polls. We will discuss that things also. I'm launching a poll. There are 5 questions. Last one is you can choose multiple options. Remaining thing is choose one option. Dr. Surendra Dabas, over to you. Will you introduce the panelist also?
Yeah, I will do that. So
sure.
It's right now the poll is going on, na?
No, you can continue with your talk. Introduce your panelists, and I think the poll can run simultaneously.
Okay.
Yeah, I think I need to stop it. Otherwise, you can. So, will you introduce your panelists? Then I'll stop the poll.
It's fine. So right now we have, so good evening everyone, and thank you Dr. Chandramohan for conducting a panel for early lung cancers. So I will introduce the surgical oncologists. These are the eminent surgical oncologists. Dr. Rajesh Mistry is there, Dr. Chinnababu is there, and then we have Dr. Sabir Javeri. Then we have radiation oncologist Dr. Srinivas. Then we have Dr. Natasha from Canada. She's a medical oncologist. We have Dr. Anuradha, she's a scientist from Tata Memorial Cancer Center. We have Dr. Narasimhan, he's a pulmonologist from Apollo Cheney. So we have surgical oncologists, radiation oncologists, and medical oncologists, scientists, and pulmonologists. So we will discuss about early lung cancers. So it is the summary of all lectures given right now by Dr. Rajesh, Dr. Anuradha, and Dr. Natasha. So can we end the poll right now? It's
yes,
on my screen.
I'll do that. I can see your slide share screen.
Okay, you can see that.
Okay, I'll stop.
So we can see the slides.
Natasha, can you see the slides?
Can we all see the slides?
Yes, yes, yes.
Yeah. So the issues what we are discussing in the panel is how we do a pre-operative assessment of early lung cancer. And the lecture was taken by Dr. Rajesh Mistry, well detailed lectures about mediastinal staging and everything. Then right now we have a situation with the COVID-19. There are a lot of dilemma. People get lung nodules during the screening or during an evaluation by PET-CT. How we manage that? Mediastinal staging. And what are the surgical approach? We do a lobectomy by VETS approach or by robotic approach. Lymphadenectomy. The use of staplers nowadays with the robotic technology. SBRT and adjuvant therapies, and a very well detailed lecture taken by Dr. Natasha. So we have a case who is a 56-year-old gentleman, no comorbidities, chronic smoker, no specific chest complaints, and he got a CT chest done and showed 2.7, 2.6, 2.5 centimeter left upper lobe mass with sub-centimeter mediastinal and hiatal lymph nodes. So my first question is to the surgical oncologist. Dr. Rajesh is there, Dr. China Babu, and Dr. Javeri is there. So how you evaluate this patient once you get a CT chest? Should we do a PET CT in all patients? Do you recommend biopsy before PET CT, or we do a PET CT and then do a biopsy? Dr. Rajesh?
Yeah, do you want me to start?
Yeah, absolutely, sir.
So yes, in this patient, a PET CT scan is very much in order, and unless there is, a doubt about the character of the primary lesion, I would do, CT guided biopsy straight away, and then do a PET CT scan. Though the order can be reversed. I mean, there's not anything sacrosanct about the order of performing PET scan and a CT guided biopsy.
And Dr.
I
China
agree.
Babu?
And
Okay, Dr. Natasha.
oh, sorry. I agree. And, I find in Canada, it takes so long to get the patient from that sort of cough to the family doctor, to the CT, to the surgeon, that, we have a rapid diagnostic program where we get the referral. The patient gets seen within 24 hours, and we try and do all the tests. Like, we just get them done within a week. We meet, we review the imaging, and then they plan, do they need an EBUS? Do they need a transbronchial biopsy? Are they clearly advanced? How do we fast track them to the different systems? It's a bit easier for us because we probably don't have as many patients. We probably have more doctors, but I agree, just sort of get it all done in there with the biopsy.
Now, can I get in?
Absolutely, sir.
Dr. Narasimhan. No, I'd like to know which is the first preference. Is this a bronchoscopic biopsy or a CT guided biopsy? That's the usual dilemma many people have. As a pulmonologist, I think a bronchoscopy is very much warranted. To give an information to the surgeon as well, whether the airway involvement is there, and also if I can see in the bronchial is something, I will have the option of taking a biopsy as well. So my choice would be for a bronchoscopy and an endobronchial biopsy or a transbronchoscopic lung biopsy. The first option, so that I look at the airways, number one, number also I take the biopsy. Then, of course, I prefer a CT guided biopsy. I just want what the Canadian saying.
So, it's so hard because the surgeons and respirologists say one thing and the medical oncologists say another, and the pathologist kind of depends on who they are. So, I think we all agree minimally invasive or sort of first procedure, make the most of it. So it's usually bronchoscopy. But, we found from molecular testing that, especially bronchial washings and brushings were largely unsuccessful in terms of having successful testing. So we really wanted things with more tissue and more cancer cells. So, I think both FNA and core biopsies have similar outcomes, but we really don't think things like washings or brushings are enough. We really want a chunk of a tissue. If you're going to do an FNA, can we get a cell pellet, just enough to do molecular testing? So I think that's sort of 2 for 1: get enough for the diagnosis and then get enough for the molecular profiling. And so I think that's what we do with EBUS. A lot of our patients will have bronchoscopy and EBUS, but, especially if they've got a peripheral lesion, or, I have a lady, she's got a huge left-sided lesion, but she's got right axillary nodes. So we're going to do a guided biopsy of the right-sided nodes, because that's going to sort of, is this two cancers or is this one, strange lung cancer? So I think it varies, but as long as you get, if it's FNA and you really need that cell pellet.
It is in peripheral tumor, so we don't advise bronchoscopy in peripheral tumors. But yes, if you are seeing some mediastinal lymph nodes and higher lymph nodes, many of us will advise EBUS. So we may do a PET CT, and PET CT may not show uptakes. So how many of us will recommend an EBUS for mediastinal staging? Even the PET CT says they are not PET avid lymph nodes in the mediastinal.
Can I comment?
Absolutely, sir.
Yeah. So I generally use my, but if there is a clinical suspicion of malignancy or a radiological, there's a PET shows a definite malignancy, and there are some lymph nodes which are sub-centimeter, even though there is no take-up. There are a lot of instances, there are a lot of papers where there are PET negative and EBUS positive lymph nodes are there. We also have picked up many times the EBUS positive malignant nodes. So I would prefer in one sitting itself both doing a bronchoscopy and the EBUS if the PET scan is showing positive. It gives a lot of information to the operating surgeon and also to the medical oncologist to plan their therapeutic strategies. My preference would be for a both bronchoscopy and EBUS in one sitting if I find a subcarinal and a hilar node, or a right-sided node. Fine. Even though there is no PET taker, I would prefer to do an EBUS and bronchoscopy.
So it means even it is T1 tumor or it PET CT says no lymph nodes or lymph nodes, we should always do an EBUS, because as Dr. Rajesh told us, you can have a concomitant tubercle pathology in the lymph nodes. So you should always see the lymph nodes are tubercular or malignant. So we should always do an PET CT, even if it's T1 lesion, and we should always advise EBUS for all either peripheral tumors or central tumors. So this is the take-home message for all the attendees. Dr. Natasha?
Yeah, I agree. I think that mediastinal confirmation is so important. And in Toronto, we only use endobronchial ultrasound now. It's almost unheard of to go to a mediastinoscopy. But you will see surgeons, if it's a small peripheral T1, you will see surgeons just going straight to the OR. Now, they still do sampling, intraoperatively, but I think, I agree. I think best practice is to know before you go in. But I agree, we still do see a lot of people going straight to the OR with a negative PET and just a stage 1 or a T1 lesion.
Dr. Rajesh want to say something?
Yeah, I think if the primary tumor is peripheral and small, what Natasha said is absolutely right. As a surgeon, we can go ahead with surgery without doing a mediastinal lymph node evaluation, because if the PET scan is negative, the tumor is peripheral, the chances that mediastinal lymph nodes are going to be positive is very less. And we also know that if the nodes turn out to be metastatic, it is going to be occult metastasis, microscopic disease. And this is a subset of patients who do well even with upfront surgery.
So the take-home message is that if it is T1 tumor, no notes on PET CT, we are just going ahead with surgery directly. And if it is not positive on PET CT, we should always do an EBUS to prove that it is tubercular or it is malignant. Am I okay, sir?
That's right. Or whatever. I mean, you have to rule out malignancy. That's for sure.
So what are our recommendation of the panelists for getting an MRI brain in early lung cancers?
Not in patient with tumor which is less than 3 centimeter and peripheral, but anything else, you should do an MRI before taking up the patient for surgery, because PET scan, as we all know, is not good for picking up small
Brain disease.
metastasis in the brain. Yeah.
So Dr. Natasha, you people recommend MRI brain for early brain lung cancers?
We do. Our team does routinely do brain scans. It is interesting, though, 1,000 years ago, 20 years ago, we did a randomized trial called the Big M trial, where we showed there was no difference if patients didn't have symptoms and you imaged the brain or not. Now, that was with CT. But it is interesting. Despite that, we still do it, and it is reasonable, right? I mean, I think especially if somebody has multifocal disease, there's a lot of talk about how do you treat that person with the isolated lung lesion and brain disease. But maybe that's for another meeting and some more challenging cases. But I agree. I think patients should get their brain imaged, especially these never smokers with EGFR and ALK and ROS1.
Dr. Sabir, you want to say something? Dr. Zaveri?
Yeah. No, it's. I mean, I would agree with Dr. Mistry that for peripheral lesions, a PET and a transthoracic needle aspiration or a biopsy is enough to go ahead with and do a surgery if there is no mediastinal lymph node involvement.
So the take-home message for
practice. I mean, that is the practice we have at Manipal Hospital. We wouldn't want to do a bronchoscopy or an EBUS in such patients.
So the take-home message for MRI brain is that for early peripheral tumors which are less than 3 centimeter, don't advise MRI brain. But if it is more than 3 centimeter, we always advise MRI brain. And PET-CT is recommended in all patients, and plus minus EBUS depending on the metastatic staging. So evaluation for early cancers is over. So now this is for Dr. Anuradha. That's why your lecture was there. We always ask for doing an EGFR, ALK1 or PDL1 in all early lung cancers.
Yeah, as I said, EGFR and ALK actually can be done. So we can get parallelly the ALK report as well. And EGFR testing should be done. But again, as I mentioned, if you're going for the NGS panel, that is more preferable. But it takes a time for the NGS report. So EGFR testing should be done as a complementary, where you can get the report within 8 to 10 days.
So you want this panel to be done on a pre-operative biopsy, or you want on a biopsy or the operative specimen?
On the operative specimens, because you need to have some more tumor content cell, and maybe in the pre-operative biopsy we may miss some tumor cell content, and the true biopsy will be the post-operative biopsy will be the most representative.
So Dr. Natasha, any say on that? You want to go for any pre-operative neoadjuvant, maybe an I will say immunotherapy for the early lung cancers, what the trials are showing to us. So you need all these on a pre-operative biopsy. Am I right?
I think if you're going to use the preoperative approach, you would need more data. But I agree with Dr. Anuradha. I mean, it's a challenge, right? These are small samples. These are not big samples. And even though NGS is getting better, a lot of our patients with these tiny little samples pre-op, you just can't do NGS. So in our group, for example, we're thinking of participating in Neo-ADORA. And so the surgeons came to me yesterday and they said, oh, we want to do it. You got to open it. And I thought, how am I going to get EGFR testing on these teeny tiny samples? So we're trying to see if maybe we can do ddPCR before. Most patients, if the tumor is a centimeter or larger, they'll already have something in blood. And then is that a way that I can sort of pull out a group that we know are going to be EGFR positive? We can take their pre-specimens and go from there. And also that's maybe why adjuvant is an easier approach, right? Just like Dr. Anuradha said, you have the whole tumor, you can do it, you have a little time, you might give adjuvant chemo. And that's why I suspect adjuvant is going to be much more popular and mainstream than pre-op, although, I think pre-op probably still tells us more.
I agree with you.
So this is the NCCN guidelines, what we discussed in past 2-3 slides. So this is the PET-CT of a patient showing a peripheral tumor. It was T1 on CT scan, but now the PET-CT says that size is around 3.2 centimeter because it's T2, again N0. And it is peripheral tumor of the left upper lobe. So now the recommendation. So now there are a lot of recommendations. Now we are discussing about directly we should go for surgery. Are we thinking about SBRT? Or as we talk about neoadjuvant chemotherapy or maybe an immunotherapy in EGFR positive or ALK positive patients. So I think most of us I will agree for surgery first in these patients. But I want to ask Dr. Srinivas, who is the radiation oncologist from Apollo Chennai. Sir, any role of SBRT in these patients?
Well, SBRT is a reasonable alternative in many patients of T1 lung cancers for sure. This is a slightly bigger lesion, which is more than 3 centimeters. The mediastinal staging becomes extremely crucial in such settings. But nevertheless, SBRT is a very good alternative in T1 lung cancers. And now that we have long-term data in carefully selected patients with STARS Rosal, the pooled analysis which got recently presented at ASCO 2021, we have now long-term data which actually shows that 5-year overall survival is up to 87%. So certainly is a consideration in certain group of patients. That is generally a broad MDT discussion. Well, with this patient, especially with more than 3 centimeters, surgery is definitely a slightly more preferred approach than SPRT. There's no doubt.
So any role about neoadjuvant chemoradiation in these patients, or only chemoradiation for the early lung cancers?
I really would not recommend neoadjuvant approaches in this particular situation. It would be either upfront surgery or SPRT, and nothing else. That would be the right way.
So we agree
I
for
think,
just to
sorry.
Yes,
I certainly agree. I think when you're in clinic and you're selecting the patient for pre-op, it's usually somebody with like nodal disease or someone where there's surgical challenges, right? Most of our patients, they just want to either get to the radiation suite and have their SBRT, or they want to get to the OR. So again, I think, the world will go for upfront curative surgery and then adjuvant after.
So now we are agreeing for that we should go for a surgical approach for this peripheral, it is a T2 tumor on PET-CT, and we always do some lung function tests before planning surgical approach to these patients. Now it is for surgical oncologists, Dr. Rajesh, Dr. Chinababu, and Dr. Javeri. So what is your approach for doing a lobectomy? You want to go for open or VETs or robotic assisted lobectomies? So Dr. Rajesh.
Yeah, so in today's setting, minimal invasive surgery is always preferred. So any patient in my policy is to always attempt minimal invasive surgery before you change over to open surgery. At the same time, looking at the kind of patients we see in India, large tumors, patients with adhesions, fissures being very ill-defined, there will be instances where you have to convert from minimal invasive surgery to open, and one should not feel bad about that. But first, we should always make an attempt at minimal invasive surgery.
Mr. Beer? Dr. Chinababu is there.
Yeah, Dr. Surendra, I think as Dr. Mistry has rightly put it across, minimal invasive is the order of the day. So may it be VATS or robotic. And many times we have had challenges of converting them into open as well because of the various reasons mentioned before.
Dr. Sabir? Dr. Javeri? Are you there? So is the COVID situation changing your practice from open, VETs or robotic?
That's a very difficult question, but certainly I think there are some challenges in the context of COVID, especially with respect to the the adaptation into minimal invasive surgery, wherein we have the risk of COVID transmission, especially with the aerosol formation, the pneumothorax, and all these things. So I think if you can take certain precautions like aerosol or the smoke evacuators, simple universal precautions, I think with all these we could still do the best job without much of a risk to the operating team.
So I know it is stage 1 cancer, so you want to take help from Dr. Natasha in this time so that she can give some pre-operative chemotherapy and just wait and watch and do surgery after some time once the COVID situation gets stabilized. Dr. Natasha?
I will say that we were lucky during COVID that our operating rooms, cancer surgery was still prioritized. So people could still do urgent cancer cases. So most of the stage 1 and stage 2 patients, they waited for their surgeries. They were just delayed a little bit. The stage 3 patients, though, even those that might have gone to surgery, and maybe some of the stage 2 as well, they did come for preoperative therapy. And so we tried to put them on all the trials. I've got a case of a guy who was supposed to have trimodality for N3. So we gave him chemoradiation, then the operating room's shut, and I put him on durvalumab, like for Pacific. And then finally the ORs reopened and the surgeon said, well, I'll take him back and do surgery. So, you know, I think COVID has taught us a lot. Stage 1, though, ideally we would try and wait. I don't know what you guys have been doing in India with like the stage 1 or how bad the delays are.
Rajesh?
Yeah, about this COVID situation and doing surgery, I think, you know, at least we have not, you know, delayed surgery because of the COVID situation. I don't think it is indicated also. The simple reason is that patients who would be treated with chemotherapy or radiation therapy instead of surgery because of COVID situation, one should realize that these patients also need to visit the hospitals, whether it is for chemo or radiation, and the chances of them getting infected with COVID is also going to be there. So I don't think that just because of the COVID situation, one should recommend delay in surgery and buy time with either chemotherapy or radiation therapy.
So the very honest questions about, do you want to go for VETS or robotic surgery? So patient asks you, so you tell me the best. It is VETS or robotic. So what do you say? Why VETS is better or why robotic is better for the patient? Dr. Chinnababu?
I don't think either of them. It all is a surgeon's preference and the confidence and the number of volume of surgeon that he has per year. So either of the two is good. And probably I, being a robotic surgeon, I would prefer robotic assisted thoracic surgery. But I think, you know, the ball is out. I mean, it is your preference rather than the patient's preference in that sense.
Dr. Rajesh, so we have seen you are one of the most prominent or eminent thoracic surgeon. You have trained people in open surgery, then into VETS, and then in robotic. So we, as a young guys, we have just went directly to robotic surgery. I can say that. So I'm just seriously asking you, what you prefer, VETS or robotic?
Like, you know, both VATS and robotic are comparable in terms of the acute problems that patient faces because of thoracotomy. So in terms of pain, in terms of recovery, both VATS and robotic are equivalent, and there is not much to choose. And therefore, I completely agree. The decision is mainly, you know, based on surgeon's preference and to, more importantly, patient's pocket, whether they can afford it or not. Because at least in our setting, robotic surgery would cost at least more than a lakh, rupees 1 lakh more than for VATS surgery. And when the outcomes are similar, I find it sometimes difficult to, you know, convince patients for robotic. Honestly speaking, I leave it to the patient. There are some set of patients who would come with an idea of robotic and they want only robotic. If the patient is, you know, open to both, I would just leave it to them, you know, what they want to do. So I don't have preference of one over another.
So Dr. Srinivas, during this COVID time, did you get more referrals for early lung cancers going for SBRT? Because many surgeons in the first wave, they avoided doing surgery. Basically in thoracic surgery, I can say that because it was set in the first phase, because of aerosol degenerations, if people were not doing laparoscopic surgery or maybe VETS or robotic. So do you get a chance to treat more early lung cancer during that time with SBRT?
Actually, we did. I think because of the COVID and increased prevalence of using CT scans, we were able to see more early lung cancers than a routine practice, and we did see patients of early lung and stage T1 lesions, and of course, you know, the biopsies also got delayed. Everything got delayed, but despite that, I think there have been one positive thing which has happened in this pandemic is we have been able to detect a lot of patients with early lung cancers. Whether they have been, you know, receiving SBRT, that is a question which, you know, that depends on institute per institute and depends on the institutional practice. But I think that we did slightly increase the rate of SBRT in the last 1 year compared to the previous years.
Because the surgeons will never prefer to send a T1 lesions to a radiation oncologist because we get T1 very rarely. So they all want to operate, but during this time, many people are not operating.
Yes. So those months, of course, most of the patients actually waited for surgery, waited for the elective surgeries to begin. It's not that they have been referred to us, but in exception, in more situations, we've received referrals and inquiries from anxious patients before they, they could wait for surgery. Some of them actually would come for an opinion for an SBRT, and some of them did end up receiving SBRT.
Natasha, want to say something?
In Canada, especially during our third wave when we didn't really have ICU beds, there was a shift from these early stage lung cancers going to radiation. But what we found in Canada was that we actually weren't diagnosing people at early stage. We were diagnosing people at late stage, because that sort of primary care net where patients get diagnosed, that was all closed. All the family doctors' offices were shut. So what I used to see, stage 1 to stage 4, but during COVID, like we've really just seen stage 4. Because people stay home, they don't come to hospital, they don't get diagnosed, then they're in extremis, they go to emerge, boom, they have lung cancer, no time for profiling, no time for anything. So that's what it's been like for us with the shutdown of the hospital system.
So Rajesh, want to say something?
Yeah, so this is very paradoxical, like all of us experienced more so during the second wave. People were very willing to get an HRCT done in view of the COVID pneumonia, and many places that was the primary way of diagnosing COVID. And we have been picking up a lot of patients. In fact, every OPD, particularly during this second wave, I am finding patients who have coming with either incidentally diagnosed early lung cancer or a thymoma or some mediastinal lymphadenopathy. So I'm quite this is something of an education for me, that COVID caused diagnosis of more advanced cancers in Canada, whereas the exactly opposite happened in India.
So sir, we should focus on screening for lung cancer, at least in India.
Absolutely. With this experience, I feel HRCT should become a norm in people who are at high risk of cancers, lung cancers.
Dr. Chandramohan, can you remove this poll
Sure.
on my slides? I'm not able to move my slides.
Sure, I'll do that. I'll stop it. Where is poll? Okay, 1 minute.
Can
Dr.
you remove it?
Subramanian Rao, yeah, I am poll.
I'm not able to. Yeah, I'm not able to do it.
Yeah, I stopped it. Is it okay now?
But it's still coming on my slides.
I can see the slides.
Here you can see, but my slides has.
So Tapas, you need to just cross it, because it used to come on my screen. You just cross it and it will go away.
Okay, sir. I lost my cursor.
No?
So there's some comparison between VETS and robotic, and it says that the only thing which robot gave us is we have high lymph node retrieval when you do a robotic surgery as compared to VETS and open, and may improve our mediastinal staging. And we know doing robotic surgery is costly and time consuming initially when you're taking this technology, but yet it is one of the best technology for thoracic surgery because the blood loss is very less, the high three-dimensional surgery, and it gives and better control over instruments as compared to VET's instrument. So the chances of vascular injury is less, but all matters is your training. Are you a VET surgeon or you're a robotic surgeon? It matters. There are multiple trials going on, VETs versus robotic, but the survival is same, either do VETs or open or robotic surgery. So now there is an robotic staplers has been introduced by the company. And initially we were saying that when you do and VETs, sometimes we have when we are doing a robotic surgery, we don't used to have robotic staplers. Is the robotic staplers helping us, Dr. Rajesh and Chinababu, in your practice for doing a lobectomy?
So I have never used the robotic stapler, but I would love to use it, and I find it. I would imagine that it would be very useful, because one of the key difference between VATS and robotic surgery is that when it comes to VAT surgery, I can do it with first year resident also. However, if I am doing robotic surgery, I want an experienced assistant because he's the one who's going to insert the staplers, around the vessels, the bronchus. And it is always nerve wracking. You are sitting on the console and somebody else is doing the difficult work. But this obviously would make it easy and you will feel safe doing robotic surgery. So
Dr.
I haven't
Chinna,
used it up till now.
Yes, Doctor.
any experience with this, Dr. Chinnababu?
No, Dr. Surendra, I'm yet to use the robotic stapler. And as Dr. Mistry sir has rightly said, I think robotic surgery is basically a VATS and robotics actually, because you depend so much on your assistant here in robotics with so much of stress during the firing of these staplers. So I think new innovation in this space will certainly, would be, great acumen for us.
So I will say we are lucky to use this stapler, and I can say you that. So when you're doing VATS or even a robotic, open thoracotomy, sometimes you cannot place your staplers in a direction. But when you're using the robotic staplers, it is under your control, and you can put it across the vessels, the less chances of vascular injury. But right now, the staplers are available in 60 size. You don't have smaller staplers like 30 and 45. So sometimes it's difficult to use in 60 stapler, but maybe in future they will have 30 and 45. And it is one of the most technology which is improved by a robotic company for our future use. It is going to help us in a very good way. So this patient underwent left upper lobectomy with the robotics technology, and if you see the histopathology, the tumor size was around 3.4 centimeter. It becomes T2, all lymph nodes negative, grade 2 margins free, 17 lymph nodes all free. So now, Dr. Natasha, are you here?
Oh, yes, I am. Hi.
So yes, what is your further take about these patients? You want to go for an adjuvant chemotherapy, or if you do an EGFR, if it is positive, you want to go for osimertinib for these patients?
So I think, adjuvant chemotherapy, we restrict to node positive, as you know, or tumors that are greater than 4 centimeters in North America, which is not sort of commonly practiced outside North America. So this patient wouldn't qualify. We wouldn't offer this patient adjuvant chemotherapy. If they were EGFR positive, though, if Dr. Anuradha's team said, this patient has an exon 19 or an L858R mutation, technically they do fit into the ADAURA population and would be eligible for adjuvant TKI. Right now, the Canadian government has approved the ADAURA protocol. They've approved the inclusion criteria. They would like to get to an affordable amount. But I think one of the issues is that benefit in 1B going to translate to an overall survival benefit? If I can get the drug for free, I talk it over with the patient, I'd offer it. If the patient has to pay, I don't know. I don't know that an overall survival benefit in that kind of tumor. But I'll turn it back to my colleagues who have a lot more experience in practical issues like that.
So Dr. Rajesh, what do you advise your patients? You say you go to the medical oncologist and they will decide, or you say go for chemo, or you want to say go for target therapy?
No, I completely agree. Tumor less than 4 centimeter, there is no role for any kind of adjuvant treatment as of now, apart from the ADAURA trial. But what I would like to know from Dr. Natasha is, this new the parameter which is always reported in pathology specimen of spread through air spaces. You may have a small tumor, but particularly what we used to.
I agree with you. Oh, sorry.
These patients we know are at very high risk of recurrence. Keeping that in mind, do you advise adjuvant treatment for such patients in spite of the size which may be less than 4 centimeters?
So we have not been, but it comes up at rounds once a month.
Right.
So, we, like you, STAS, we know it's real. We know it's a poor prognostic factor, kind of like lymphovascular invasion, but the same for, LVI. We don't recommend it to those patients either. When we looked at the BR10 data, it was really size, it was T size that dictated the benefit or end stage. So we discuss this, if we're really worried about a patient, we might discuss going sort of off label, but that's rare, like a 35-year-old with, so I think we would not based on STAS alone. How about you? Would you recommend based on STAS alone?
No, like you said, I have a gut feeling that we should offer, but we don't have evidence whether that adjuvant treatment is really going to help or no. So as of now, my medical oncologist would not agree.
Sir, as per the guidelines, the medical oncologist says that with more than 3 centimeter, now they are recommending adjuvant chemotherapy for these patients. So I want to ask Dr.
Surendra Dabas, I acknowledge the presence of Dr. Subramanian Rao. Can you ask the same question to him? Sir, would you recommend osimertinib and adjuvant chemotherapy for early lung cancer? What is your practice? And what is in the view of the recent evidences, are you switching your practice or are you happy?
I don't know. We have not discussed this as yet, but at present, I think we should not be doing.
Okay, back to you, Dr. Surendra Dabas.
So now, Dr. Srinivas, any role of adjuvant radiation therapy in margins-free resections of early lung cancers?
The short answer is no. If I have to elaborate, these are precisely the patients in whom the evidence says that the radiation leads to detriment in survival. So definitely no in this R0 resected patients, and especially with no negative, absolutely no indication for postoperative radiation.
So suppose we have an it's a margin positive resection and the bronchial margin is positive. So what is our say now? We want to go for adjuvant chemo first or maybe only adjuvant radiation?
Bronchial margin is positive?
Yeah.
So that is interesting because conventionally we have been treating margin positive patients or those with multi-station N2 disease. There is evidence to say that the adjuvant radiation therapy leads to improvement in local control, not in overall survival. And that is a reason to offer postoperative radiation or discuss postoperative radiation in those patients. A recently concluded post-op RT adjuvant radiation therapy trial is not yet published, but was presented last year at ESMO, which actually showed that adjuvant radiation therapy did improve disease-free survival, and there was that was statistically significant, but that did not translate into overall survival, again because probably patients who were treated with adjuvant radiation were having more cardiovascular effects, which was nullifying the benefit with respect to the disease-free survival. So as of now, the literature is divided, and this requires a little bit of more of a nuanced approach, more of a discussion. Depends on what kind of patient it is, what is the risk, and if it's a node negative patient, probably adjuvant chemo alone would be sufficing. If it is a node positive and N2, so there are multiple risk factors, then probably yes. If it's a young patient, definitely post-operative radiotherapy could be preferred.
Despite the lung art results?
Yeah, the lung art results have been presented, but not yet published. So obviously, as I mentioned, the adjuvant radiation therapy did improve disease-free survival, Dr. Natasha, in that lung art study, but it did not improve overall survival, which was the primary endpoint of the study. I think that's what it requires a little more of a discussion in such situations where if it's a young patient and there are multiple risk factors, local control is a important criteria, then adjuvant radiation therapy could be on the table, which could be discussed.
Rajesh, want to say something?
No, I think adjuvant radiation therapy is indicated when you have margins which are positive, because though it may be easy to say that one should go down and resect it, it becomes very difficult after lobectomy. So I would agree with post-op radiation therapy in presence of positive margins. The other place where I liked adjuvant therapy, chemoradiation therapy rather, is when you have done a complete mediastinal lymph node dissection, but the specimen shows that there are multiple lymph nodes positive. Now, I don't know if whether that will improve overall survival, but at least loco-regionally they remain controlled. So that's a plus.
So Dr. Srinivas, I want to ask you one thing. So if you're planning adjuvant radiation therapy, so what will be your doses to the bronchial stump?
So ideally, 50 to 54 gray in a completely resected disease would be the standard of care, and probably 54 to 60 in patients who are margin positive disease. I would obviously prefer probably the most conformal radiation approach to limit the doses to the cardiovascular structures in the mediastinum. So 54 to 60 would be the ideal choice.
You know, it's so interesting to hear you talk about adjuvant radiotherapy and N2 disease. So, you know, when the lung art trial came out, so our group really liked to radiate postoperatively for N2 disease. And when that study came out the first month, they all said, oh, disease-free survival, it's good, we're going to keep doing it. And then 6 months later, with actually one of the rad oncs was presenting this at the surgical meeting, and he said, you know, I've been through it, and he said, you know, I may as well just radiate at relapse. So, you know, I think you're right. It's something for discussion, and I suspect the radiation oncologists kind of are finding the medical oncologists kind of going after them. but you could argue it's the same as adjuvant TKI and immunotherapy right now, right? We don't have survival, so should we be doing it? It's a good question.
So this was the adjuvant chemotherapy for non-small cell lung cancers, and what they say is stage 1B onwards, if the tumor is more than 3 centimeter, and if the tumor is increasing centimeter by centimeter, the role of chemotherapy is increased and it improves the OS. So this was if you are giving chemotherapy in stage 1B, the chances of survival benefit is less, but if it is stage 2 and 3A, the chances of survival benefit is more. So we always recommend chemotherapy once the tumor crosses more than 3 centimeter. So now this is what we have discussed about biomarker testing, and Dr. Anuradha and Dr. Natasha have already answered about this. We can do biomarkers in pre-operative specimen, but we need a good tissue for all NGS and all these biomarker studies. And we should always do in early cancers, all these biomarkers should be done. And this is a Dura trial shown by Dr. Natasha in her presentations about the benefit in DFS. So now the role of radiotherapy was already discussed. The role of PORT in early lung cancers with margin negative resection is not recommended. But for margin positive, yes, we should give RT to the bronchial stump. But we never covered the mediastinum if it is N0 in this post-operative radiation therapy, Dr. Srinivas.
Yes, we don't. We don't. And if multi-station N2, we do cover the mediastinum only, and not the bronchial stump.
So this is a question to Dr. Rajesh, because he's one of the most eminent thoracic surgeons across the country. So do you do an intra-operative bronchoscopy when you are doing a surgery to see you are doing a margin-free resection of the bronchus? Because it makes a huge difference for patients, because giving around 50-54 gray to the bronchial stumps may sometimes lead to bronchial stump leakage and leading to a lot of morbidity and mortality. So we do intraoperative bronchoscopy, or we don't recommend that?
No, we do pre-op bronchoscopy and confirm that the level at which you're going to actually transect the bronchus is going to be tumor free, because I don't think doing intraoperative is going to make any difference. If you know that the margins are going to be free grossly at least, um, pre-operative bronchoscopy is good enough, because intraoperative also you're going to see that only. You're not going to see any microscopic disease. And most of the time it is the microscopic disease which you will see at the cut margins, not the gross disease, because that nobody will do it. As soon as you fire the stapler and you realize that it has gone through tumor, you would want to revise it at the time of surgery itself.
So many times, sir, Vijay as a surgical oncologist don't do an pre-operative bronchoscopy for peripheral tumors that we were discussing earlier. We always see the peripheral tumor and we do a CT guided FNAC or biopsy and just take up the patients. If the PET scan says no mediastinal lymph nodes, we take up for surgery. So in these cases, do you recommend, if you have not done a pre-operative bronchoscopy, do you recommend an intraoperative bronchoscopy for these patients?
No, if the tumor is peripheral, then there is obviously unlikely to be disease in the bronchus. So, I mean, I would actually recommend doing bronchoscopy for any surgery,
Okay,
even
you
if it is
would.
peripheral or central. Yeah,
So
because you need to
bronchoscopy
know
is
what
recommended
is
for all
happening in
patients.
the bronchus. Yeah.
So this is a discussion about early lung cancers. We should do what evaluation we should do, how we manage the patient, we do surgery or SBRT, or we then what the biomarkers as needed for the early lung cancers and the use of these biomarkers in adjuvant setting to give more DFS. So this was the discussion about early lung cancers. So this is from my side. Any panelists want to just enlighten any other issues in early lung cancers is most welcome.
Thank you, Dr. Surendra Dabas. Actually, you nailed it. You actually concluded the whole spectrum of early lung cancer has been covered. And now there are certain logistic issues like many of the centers in India are not having that access to laboratory to the CGFR mutation. For that, the AstraZeneca is having some support programs. So I invite Dr. Mr. Srikant Tota, the person representing AstraZeneca, to say about that program in 2 minutes. Srikant, over to you. Surendra Dabas, can you stop sharing your slides so that he can share his
Yes,
slides?
sir, I can do that. For my, because I don't have my key with me, it's not moving. So
Okay.
I don't know why it's not moving. Just a second. And now I can do it. It's done.
Thank you.
Sir. Thank you
Yes,
very much, Dr. Chandrasekhar, sir. I'm Srikant Tota, Diagnostic Liaison Manager from AstraZeneca India. So we would like to inform that AstraZeneca has launched a patient support program, free EGFR test. This free EGFR test can be availed by the patient who are in early lung cancer, that is stage 1A to 3B patient, early lung cancer. I'll just share the coupon with you. So hope my screen is visible.
Yes.
Yeah, so in order to make this test, quality test, access to all the early lung cancer patients, so we have launched this free testing program. So I request all the surgical oncologists and the clinician to make avail of this facility, and so that the many of the patient can be benefited with the free testing. So this is a one announcement, and we request we thought of bringing to your notice. So thank you, sir, for this opportunity.
So this is only for EGFR?
Yes, sir. This is only for the EGFR, and the patient has to be in the early stage, that is stage 1A to stage 3B.
Not for stage 4?
No, sir.
Thank you, Mr. Srikant. Actually, it was a fantastic evening, and we have a good number of people. Nearly 100 people are attending this meeting. I never expected this, and thanks to speakers. And let me invite Dr. Sharad Desai, for the Honorary Secretary of IAS, to say a vote of thanks.
Thank you, Dr. Chandramohan. In fact, we had a great webinar today. Thanks to the Kerala Association of Surgical Oncology. Lung cancer is a very uncommon cancer, and most of the time it's our non-surgical colleagues who have always taken this central stage. For a century, probably 100 years, there has been hardly any major breakthrough as far as lung cancer is concerned. But now, since the last few years, we are back to from the century of nihilism to a phase of optimism. So whether it's the surgeon, whether it's the radiation oncologist or the medical oncologist, everybody is coming in the power mode. So with the advent of VATS and robotic surgery, lung surgery has also been, there's been great interest in lung surgery. So I take this opportunity to thank our speakers, our very reliable Dr. Rajesh Mistry sir, and the other speakers, Dr. Chogle madam, Dr. Natasha, who has joined us all the way. It's always a great pleasure for the Indian Association of Surgical Oncology and KASO to have a foreign speaker on board. And of course, our extremely reliable Dr. Surendra Dabas has moderated the panel very well. Thank you, sir. I also take this opportunity to thank the panelists, Dr. Chinna Babu. Dr. Chinna Babu looks a little more wealthy and a little more, has put a little more weight to himself. I couldn't see Dr. Shabbar here, but I also thank the other panelists, Dr. Srinivas. And I also take this opportunity to thank our team, that's the Indian Association of Surgical Oncology, and the members of KASO for organizing this webinar. And thank you, Mr. Tota and AstraZeneca for organizing this webinar for us. So thank you, everybody, and let's have a good night. And we hope to see you again soon.
Good night. Good
Thank
morning.
you very much. Thank you so much.
Thanks so much. Bye-bye.
Thank you, sir. Bye-bye. Bye.
Bye-bye. Thank you.